Question 1. Targeted therapy mechanisms. Tyrosine kinase inhibitors, TKIs, are a cornerstone of targeted therapy in oncology. They inhibit oncogenic signaling pathways essential for cancer cell survival and proliferation. Which of the following statements regarding TKIs is correct? A. TKIs primarily act by binding to extracellular receptors and blocking ligand binding. B. Resistance to TKIs can occur due to secondary mutations in the kinase domain or activation of bypass signaling pathways. C. TKIs are non-selective agents that target both normal and cancerous cells indiscriminately. D. The mechanism of TKIs is to induce direct DNA damage leading to apoptosis. Answer. B. Resistance to TKIs can occur due to secondary mutations in the kinase domain or activation of bypass signaling pathways. Bulb explanation. Tyrosine kinase inhibitors, TKIs, block the intracellular kinase domain of receptor tyrosine kinase REKS involved in cancer cell signaling. Resistance can rise through secondary mutations in the kinase domain e.g. TM mutation in EGFR mutant lung cancer or through activation alternative pathways e.g. MET amplification bypassing EGFR blockade. A. Incorrect. TKIs do not act by blocking extracellular ligand binding. They inhibit intracellular kinase activity. C. Incorrect. Unlike chemotherapy, TKIs are selective for specific mutated or overexpressed oncogenic kinases, reducing toxicity to normal cells. D. Incorrect. TKIs do not cause direct DNA damage. Their action is through inhibition of signal transduction pathways required for tumor growth. Books guidelines SEC and ESMO guidelines recommend molecular testing e.g. EGFR ALK BRAF mutations before prescribing TKIs. ESCO guidelines discuss acquired resistance mechanisms and strategies to overcome TKI resistance, such as combination therapies and next-generation inhibitors. Question 2. Scenario-based. Oncologic emergency management. Dr. Patel is managing a 62-year-old patient with metastatic prostate cancer undergoing androgen deprivation therapy. The patient presents to the emergency department with new onset back pain, difficulty walking, and reduced sensation in both lower limbs. MRI reveals an epidural spinal cord compression at the T level. What is the most appropriate immediate management for this patient? A. Start high-dose corticosteroids and urgently consult radiation oncology or neurosurgery. B. Increase at dose and monitor symptoms over the next 24-48 hours. C. Prescribe oral opioids and physical therapy to improve mobility. D. Initiate chemotherapy immediately to control systemic disease. Answer. A. Start high-dose corticosteroids and urgently consult radiation oncology or neurosurgery. Bulb explanation. Spinal cord compression is an oncologic emergency requiring immediate intervention to prevent permanent neurological damage. The standard of care includes high-dose corticosteroids e.g. dexamethasone 10 mg followed by 4-6 mg every 6 hours to reduce inflammation and edema. Urgent referral to radiation oncology or neurosurgery to consider external beam radiotherapy if radiosensitive tumor, or surgical decompression if instability or progressive symptoms. B. Incorrect. Monitoring without intervention risks irreversible paralysis. C. Incorrect. Symptom management alone is inadequate. The underlying compression must be treated. D. Incorrect. Chemotherapy does not provide immediate relief and is not first-line treatment for spinal cord compression. Books relevant guidelines. ESCO and ESMO guidelines recommend immediate imaging, steroid initiation, and multidisciplinary management for spinal cord compression. NCCN guidelines stress the importance of early radiation or surgery to preserve neurological function. Question 3. Palliative care and end-of-life communication. A 55-year-old woman with metastatic pancreatic cancer has worsening pain despite escalating opioid doses. She has also become more fatigued and has lost interest in eating. Her family asks if she should be started on total parenteral nutrition (TPN) to improve her strength. Which of the following is the most appropriate response? A. TPN is recommended because it can improve long-term survival in advanced cancer patients. B. TPN should be initiated immediately because weight loss indicates malnutrition. C. TPN is not routinely recommended in advanced cancer and supportive care should focus on symptom relief. E. TPN should be avoided and opioid doses should be halved to reduce fatigue. Answer. C. TPN is not routinely recommended in advanced cancer and supportive care should focus on symptom relief. Bulb explanation. In advanced cancer, Artificial nutrition such as TPN does not improve survival or quality of life and may cause complications such as infections and metabolic imbalances. Management should focus on palliative care interventions, including optimizing pain control, addressing fatigue and support. Emotional well-being. A. Incorrect. EPN does not prolong life in terminal cancer patients. B. Incorrect. Weight loss in advanced cancer is often due to cachexia, which does not respond to TPN. D. Incorrect. Fatigue in advanced cancer is multifactorial. Opioid dose adjustment alone is insufficient. Books relevant guidelines. ESCO and NCN guidelines recommend against TPN in end-stage malignancies, prioritizing symptom control and supportive care. ESMO palliative care guidelines emphasize discussing realistic goals of care with patients and families. Question 4. Basic science. Tumor microenvironment and immune evasion. Newly developed monoclonal antibody therapy targets programmed death ligand 1 PDL, key immune checkpoint protein that tumors exploit to evade immune detection. While clinical trials have shown improved overall survival in non-small cell lung cancer SLCA patients treated with EDLL inhibitors, responses remain variable. Which of the following factors most likely to contribute to resistance against EDLL inhibitors? A. Upregulation of alternative immune checkpoints like TIM3 and LAG3. B. Increased T-cell infiltration within the tumor microenvironment. C. Loss of PDL expression on tumor cells. D. Enhanced activation of cytotoxic T lymphocytes ETLS. Answer: A. Upregulation of alternative immune checkpoints like TIM3 and LAG3. Explanation: PDL inhibitors work by preventing the suppression of T-cell activity, allowing the immune system to recognize and destroy tumor cells. However, tumors can develop resistance through multiple mechanisms. Alternative immune checkpoints, e.g. TIM3, LAG3, and TIGIT. These pathways can independently suppress immune responses even if loss of EDLL expression, option C, paradoxically makes PDL inhibitors ineffective, but tumors may still evade immunity through other suppressive mechanisms. Increased T-cell infiltration, option B, and enhanced CTL activation, option D, are associated with improved response, not resistance. Relevant guidelines. ESCO and SEN guidelines on immune checkpoint inhibitor therapy. ESMO 2023. Mechanisms of acquired resistance to immunotherapy. Question 5. Systemic cancer therapy. Chemotherapy toxicity management. 63-year-old male with metastatic colorectal cancer is undergoing FOLFOX chemotherapy, 5-fluorouracil, leucovorin, and oxaliplatin. After the fourth cycle, he develops peripheral neuropathy, characterized by tingling and numbness in his hands and feet. His oncologist is concerned about the cumulative toxicity of oxaliplatin. Which of the following interventions is the most evidence-based strategy to manage his neuropathy while maintaining treatment efficacy? A. Immediate discontinuation of oxaliplatin and transition to different regimen. B. Reducing the oxaliplatin dose and using stop-and-go strategy. C. Initiating high-dose corticosteroids for neuroprotection. D. Continuing full-dose oxaliplatin while treating symptoms with gabapentin. Answer: B. Reducing the oxaliplatin dose and using a stop-and-go strategy. Explanation: oxaliplatin-induced neuropathy is cumulative and often dose-limiting. ESCO and ESMO guidelines recommend dose reductions or a stop-and-go approaches where oxaliplatin is temporarily discontinued after a predetermined number of cycles and reintroduced later to balance efficacy and toxicity. Immediate discontinuation, option A, is not necessary at stage unless neuropathy is severe. High-dose corticosteroids, option C, have no proven benefit in oxaliplatin neuropathy. Symptomatic treatments like gabapentin, option D, may help but do not prevent progression of neurotoxicity. Relevant guidelines: SEN and ESCO guidelines on chemotherapy-induced neuropathy. ESMO 2022, Neurotoxicity Management in Systemic Therapy. Question 6. Scenario-based. Hematologic emergencies. Febrile neutropenia. Dr. Emily Brown, an oncologist, is managing 52-year-old patient with diffuse large B-cell lymphoma EEL receiving R-CHOP chemotherapy. The patient presents to the emergency department with temperature of 39.2 deg, absolute neutrophil count ANC of 300 atmol, and mild hypotension BP 95 Hg. Blood cultures are pending. What is the most appropriate next step in management? A. Begin broad-spectrum intravenous antibiotics immediately. B. Administer granulocyte colony stimulating factor DCSF only and observe. C. Wait for blood culture results before initiating treatment. D. Discharge the patient with oral antibiotics and follow up in 24 hours. Answer A. Begin broad-spectrum intravenous antibiotics immediately. Explanation: febrile neutropenia (FN) is a life-threatening oncologic emergency. ASCO and NCCN guidelines recommend immediate Roman antibiotics even before identifying the pathogen. Delaying treatment. Option C increases mortality risk. DCSF option B may help recovery but is not a first-line intervention. Discharge option D inappropriate for high-risk patients with sepsis indicators. Relevant guidelines: ASCO 2023 Febrile Neutropenia Management. IDSA Infectious Diseases Society of America Guidelines on FN treatment. Question 7. Radiation oncology. Dose constraints and normal tissue tolerance. Patient with stidoma on small cell lung cancer SLCO is planned for definitive concurrent chemoradiotherapy. The radiation oncologist is determining the optimal radiation dose constraints for the lungs to minimize toxicity. Which of the following dose constraints is most appropriate to reduce the risk of symptomatic radiation pneumonitis? A. Mean lung dose MA equals 20 GI, 30%. B. Mean lung dose MLD, 35 GI and V 50%. C. Maximum lung dose 80 GI. D. No lung dose constraints are necessary if intensity modulated radiation therapy IMIT is used. Answer A. Mean lung dose MLD 20 GI and V 30%. Explanation: radiation pneumonitis is a dose-limiting toxicity. MLD 20 GI and V 30% are standard thresholds based on trials like ARTOG 0617. Option B exceeds safe dose limits and increases toxicity risk. Maximum lung dose option C is not as relevant as volume constraints. IMIT option D helps but does not eliminate the need for constraints. Relevant guidelines: ASTRA 2023 and ARTOG 0617 on lung dose constraints. ASTRA 2022 radiation therapy guidelines. Question 8. Molecular oncology. Targeted therapy resistance. 58-year-old patient with metastatic EGFR mutant non-small cell lung cancer SLCO initially responds well to osimertinib, third-generation EGFR tyrosine kinase inhibitor TKI. However, after 14 months, imaging shows disease progression and repeat biopsy reveals MET exon 14 skipping mutation. What is the most appropriate next-line treatment? Patient: A. Continue osimertinib with the addition of MET inhibitor like cabozantinib. B. Switch to chemotherapy with carboplatin and pemetrexed. C. Change to first-generation EGFR TKI like erlotinib. D. Discontinue all targeted therapies and initiate PD-1 inhibitor monotherapy. Answer: A. Continue osimertinib with the addition of a MET inhibitor like cabozantinib. Explanation: resistance to EGFR EKIS often occurs due to bypass pathway activation such as MET amplification or MET exon 14 mutations. MET inhibitors, cabozantinib or tepotinib, are effective in this setting. Option B, chemotherapy, is reasonable but typically reserved for later lines. Option C, switching to first-generation TKIs is ineffective after osimertinib failure. Option D, EDON inhibitors have limited efficacy in EGFR mutant SLCO. Relevant guidelines: ESMO 2023 and NCCN, Management of EKI Resistance in EGFR mutant SLC. ASCO 2022, Role of MET inhibitors in lung cancer. Question 9. Gastrointestinal oncology. Liver metastasis and surgery. 54-year-old woman with metastatic colorectal cancer ERC to the liver has 3 liver metastases, each 3 centimeters, no extrahepatic disease, and an excellent response to neoadjuvant FOLFOX chemotherapy. The tumor board is considering local therapy. What is the most appropriate next step? A. Proceed with liver resection. B. Perform stereotactic body radiotherapy SRT. C. Initiate maintenance chemotherapy with capecitabine. D. Offer radioembolization with Y90 microspheres. Answer: A. Proceed with liver resection. Explanation: liver resection is the gold standard for resected ERC liver metastases. Option B, SRT, and Option D, radioembolization, are reserved for unresectable cases. Option C, maintenance chemotherapy, is not curative. Relevant guidelines: SEN 2023 and ASCO, Management of Resected ERC liver metastasis. ESMO 2022, Role of local therapies in ERC metastasis. Question 10, scenario-based. tumor lysis syndrome in hematologic malignancies. 62-year-old man with newly diagnosed Burkitt lymphoma is admitted for urgent chemotherapy. Before treatment, he has elevated uric acid, hyperkalemia, and acute kidney injury. Which of the following is the best initial management? A. Administer rasburicase and aggressive Roman oration. B. Start allopurinol and monitor uric acid levels. C. Delay chemotherapy until metabolic abnormalities resolve. D. Initiate hemodialysis immediately. Answer: A. Administer rasburicase and aggressive Roman oration. Explanation: rasburicase rapidly lowers uric acid levels and prevents kidney damage. Allopurinol, option B, only prevents new uric acid formation but does not break down existing uric acid. Delaying chemotherapy, option C, is inappropriate in aggressive lymphomas. Hemodialysis, option D, is reserved for refractory acute. Relevant guidelines: ASCO 2023, tumor lysis syndrome managed. Question 11. Gynecologic oncology. Ovarian cancer and PARP inhibitors. 47-year-old woman with BRCA-mutant advanced ovarian cancer achieves complete response after first-line chemotherapy with carboplatin and paclitaxel. What is the most appropriate next step? A. Start maintenance olaparib, PARP inhibitor. B. Observe without additional therapy. C. Switch to non-platinum chemotherapy regimen. D. Administer intraperitoneal chemotherapy. Answer: A. Start maintenance olaparib, PARP inhibitor. Explanation: BRCA-mutant ovarian cancer responds well to PARP inhibitors. Maintenance olaparib significantly improves progression-free survival. Observation: option B increases risk of recurrence. Options C and D are not supported by current guidelines. Relevant guidelines: NCCN 2023 and ASCO. First-line maintenance in BRCA-mutant ovarian cancer. Question 12. Prostate cancer. Radiotherapy in a 65-year-old man with high-risk localized prostate cancer. Gleasonate SSA20 is recommended definitive radiotherapy. Which treatment combination offers the best survival benefit? A. Radiotherapy with long-term androgen deprivation therapy. B. Radiotherapy alone. C. Radical prostatectomy. D. Active surveillance. Answer: A. Radiotherapy with long-term Explanation: high-risk prostate cancer requires A+ radiotherapy for best outcomes. Radiotherapy alone, option B, is less effective. Surgery, option C, is not superior for high-risk cases. Active surveillance, option D, is inappropriate. Relevant guidelines: SEN and O 2023. High-risk prostate cancer treatment. Question 13. Breast cancer. Neoadjuvant therapy in HER-positive disease. 38-year-old woman with HER-positive, no-positive breast cancer is scheduled for neoadjuvant therapy. Which regimen is preferred? A. Pertuzumab plus trastuzumab plus docetaxel. B. Trastuzumab monotherapy. C. Tamoxifen. D. Capecitabine. Answer: A. Pertuzumab plus trastuzumab plus docetaxel. Explanation: dual HER blockade, pertuzumab plus trastuzumab plus chemotherapy is the standard of care. Trastuzumab alone, option B, is inadequate for node-positive disease. Tamoxifen, option C, is for ER-positive disease, not HER-positive disease. Capecitabine, option D, is not used in neoadjuvant settings. Relevant guidelines: SEN and ASCO 2023. Neoadjuvant therapy in HER breast cancer. Question 14. Hematologic malignancies. CAR T-cell therapy in relapsed refractory lymphoma. 55-year-old man with diffuse large B-cell lymphoma EEL has progressed after R-CHOP and salvage chemotherapy. His oncologist is considering chimeric antigen receptor T-cell CAR T therapy. Which of the following is the most important pre-treatment consideration? A. Assess for risk of cytokine release syndrome, CRS, and neurotoxicity. B. Perform an autologous stem cell transplant before CAR T infusion. C. Administer maintenance rituximab to prevent relapse. D. Ensure deep myelosuppression with high-dose chemotherapy. Answer: A. Assess for risk of cytokine release syndrome, CRS, and neurotoxicity. Explanation: CAR T therapy. G. Axicabtagene ciloleucel is highly effective in relapsed refractory ECL but can cause CRS and immune effector cell-associated neurotoxicity syndrome (ICANS). Option B. Stem cell transplant is not required before CAR T therapy. Option C. Maintenance rituximab is not used post-CAR T. Option D. High-dose chemotherapy is unnecessary. Relevant guidelines: ASCO and NCCN 2023. CAR T therapy in relapsed DE. Question 15. Radiation oncology. Stereotactic radiosurgery for brain metastases. 63-year-old woman with non-small cell lung cancer SLC presents with 2 brain metastases, 1.8 centimeters and 2.3 centimeters. She has no extracranial progression and good performance status ECOG1. Which radiation therapy approach is most appropriate? A. Stereotactic radiosurgery SRS alone. B. Whole brain radiotherapy with a hippocampal sparing. C. SRS followed by prophylactic cranial irradiation. D. Immediate neurosurgical resection. Answer A. Stereotactic radiosurgery SRS alone. Explanation: SRS is the preferred treatment for limited 1. 4 brain metastases due to better cognitive outcomes compared to abortion, but were reserved for multiple metastases. 4. Option C. Prophylactic irradiation is not needed. Option D. Neurosurgery is for large or symptomatic lesions. Relevant guidelines: Astro 2023 and SEN. Role of SRS in brain metastases. Question 16. Palliative care. Pain management in bone metastases. 70-year-old man with metastatic prostate cancer has severe bone pain despite NSAIDs and opioids. Imaging confirms multiple osteoblastic bone metastases. Which palliative treatment is most appropriate? A. Single fraction palliative radiotherapy, HI. B. Bisphosphonates only. C. High dose steroids. D. Radical prostatectomy. Answer A. Single fraction palliative radiotherapy, HI. Explanation: palliative radiotherapy, single HI dose is highly effective for bone pain. Bisphosphonates, option B, help reduce skeletal events but do not provide immediate pain relief. High dose steroids, option C, may help but are not first line for bone metastases. Surgery, option D, is not appropriate in metastatic disease. Relevant guidelines: SEN 2023. Radiation therapy for bone metastases. Question 17. Palliative care. End-of-life dyspnea management in lung cancer. 68-year-old man with end-stage lung cancer experiences severe dyspnea at rest despite maximal oxygen therapy. His prognosis is weeks to months. Which of the following is the most effective symptomatic treatment? A. Low-dose morphine. B. Non-invasive ventilation NIV. C. High-dose steroids. D. Benzodiazepines alone. Answer A. Low-dose morphine. Explanation: opioids like morphine are the gold standard for dyspnea relief in end-of-life care. Option B, NIV, is helpful in reversible conditions but may be burdensome in end-stage cancer. Option C, steroids, are only useful if dyspnea is due to airway obstruction or inflammation. Option D, benzodiazepines alone, is less effective than opioids. Relevant guidelines: ASCO 2023 and ESMO, dyspnea management in palliative care. Question 18. Hematologic malignancies. Acute myeloid leukemia with FLT mutation. 49-year-old woman presents with acute myeloid leukemia ML with FAT mutation. She receives induction chemotherapy with cytarabine and daunorubicin 7-3. What is the next best step in her treatment plan? A. Administer to induction therapy. B. Proceed directly to allogeneic stem cell transplantation. C. Add venetoclax to induction chemotherapy. D. Perform consolidation with high-dose cytarabine alone. Answer A. Add midostaurin to induction therapy. Explanation: FAT mutations in AML are associated with poor prognosis. Midostaurin, A inhibitor combined with 7-3 induction improves overall survival. Option B, stem cell transplant, is considered after achieving remission. Option C, venetoclax, is used in elderly infant patients. Option D, cytarabine alone, is inadequate for FLA-mutated AML. Relevant guidelines: SEN and ASH 2023. FAT-mutated AML management. Question 19. Radiation oncology. Concurrent chemoradiation for locally advanced cervical cancer. 42-year-old woman is diagnosed with FIGO stage IB cervical cancer, parametrial invasion, no distant metastases. Her oncologist recommends definitive chemoradiation. Which of the following is the best standard treatment approach? A. External beam radiotherapy, EBIT with concurrent cisplatin, followed by brachytherapy. B. EBIT alone, followed by adjuvant chemotherapy. C. Neoadjuvant chemotherapy, then radical hysterectomy. D. Concurrent carboplatin-based chemotherapy with EBIT, followed by observation. Answer A. External beam radiotherapy, EBIT with concurrent cisplatin, followed by brachytherapy. Explanation: standard of care for locally advanced cervical cancer is cisplatin-based concurrent chemoradiation followed by brachytherapy. Option B, EBIT alone, is less effective without chemotherapy. Option C, neoadjuvant chemotherapy and surgery is not recommended in stage IB. Option D, carboplatin is inferior to cisplatin in this setting. Relevant guidelines, ESCO and ESCO 2023. Cervical cancer management. Question 20, palliative care. Malignant bowel obstruction in ovarian cancer. 68-year-old woman with metastatic ovarian cancer presents with malignant bowel obstruction. She has nausea, vomiting, and abdominal distension. Which of the following is the most appropriate initial management? A. Subcutaneous octreotide and dexamethasone. B. Surgical resection of the obstructed segment. C. High-dose opioid analgesia alone. D. Total parenteral nutrition (TPN) with bowel rest. Answer: A. Subcutaneous octreotide and dexamethasone. Explanation: malignant bowel obstruction is common in ovarian cancer and often managed non-surgically. Octreotide reduces gastrointestinal secretions and alleviates nausea vomiting. Option B. Surgery is only considered in select cases with prolonged survival. Option C. Opioids addresses pain but does not relieve obstruction symptoms. Option E. TPN is controversial and usually not recommended in advanced cancer. Relevant guidelines: ESMO 2023 and ESCO. Management of malignant bowel obstruction. Question 21. Lung cancer. Immunotherapy in TIN-OS also with high allele expression. 67-year-old man with 40-pack smoking history is diagnosed with STID, ruminant small cell lung cancer SLCR, adenocarcinoma subtype. Molecular testing is negative for ALK, ALK, and ROS mutations, but P-allele expression is 90%. What is the most appropriate first-line treatment? A. Pembrolizumab monotherapy. B. Carboplatin and pemetrexed chemotherapy. C. Osimertinib. D. Radiotherapy to the primary tumor followed by chemotherapy. Answer: A. Pembrolizumab monotherapy. Explanation: allele 50% without actionable driver mutations is an indication for pembrolizumab monotherapy. Option B. Chemotherapy is typically used if allele is low or for high symptom burden. Option C. Osimertinib is for EGFR-mutated lung cancer, which is not the case here. Option D. Radiotherapy is not standard for TID-Roma disease. Relevant guidelines: SEN 2023. First-line treatment of metastatic ESLE. Question 22. Breast cancer. Neoadjuvant therapy in HER-positive disease. 54-year-old woman presents with 5 cm HER-positive, ER-negative, PR-negative breast cancer with axillary lymph node involvement. What is the most appropriate neoadjuvant treatment approach? A. Trastuzumab and pertuzumab with docetaxel and carboplatin. B. Tamoxifen followed by surgery. C. Surgery followed by adjuvant chemotherapy and trastuzumab. D. Trastuzumab monotherapy before surgery. Answer: A. Trastuzumab and pertuzumab with docetaxel and carboplatin. Explanation: HER-positive, no-positive, or large tumors warrant neoadjuvant chemotherapy with dual HER-targeted therapy. Option B. Tamoxifen is incorrect as this tumor is ER-negative. Option C. Surgery first is suboptimal as neoadjuvant therapy can improve outcomes. Option D. Trastuzumab alone is inadequate without chemotherapy. Relevant guidelines: ESMO and ESCO 2023. Neoadjuvant treatment for HER-positive breast cancer. Question 23. Hematology. Multiple myeloma and renal dysfunction. 61-year-old man presents with fatigue, anemia, hypercalcemia, 3.1 mmol, and creatinine of 250 umol. Serum protein electrophoresis reveals a kappa. Monoclonal gammopathy. What is the best initial treatment? A. Bortezomib, dexamethasone, and lenalidomide. B. Cyclophosphamide and prednisone. C. Melphalan with autologous stem cell transplant immediately. D. High-dose corticosteroids alone. Answer: A. Bortezomib, dexamethasone, and lenalidomide. Explanation: renal impairment in multiple myeloma is best treated with a bortezomib-based regimen. Option B. Cyclophosphamide is inferior for renal recovery. Option C. Transplant is not the first step in acute renal dysfunction. Option D. Steroids alone is inadequate. Relevant guidelines: IMUG and ASH 2023. Multiple myeloma treatment with renal involvement. Question 24. Colorectal cancer. For MSI metastatic disease, 58-year-old woman is diagnosed with TID, Roma colorectal cancer, MSI. Molecular testing shows deficient in MR. What is the best first-line treatment? A. Nivolumab and ipilimumab. B. FOLFOX chemotherapy. C. Cetuximab and irinotecan. D. Bevacizumab with chemotherapy. Answer: A. Nivolumab and ipilimumab. Explanation: MSI-high colorectal cancer responds well to checkpoint inhibitors, nivolumab, ipilimumab. Option B, FOLFOX, is an alternative, but less effective in MSI-high tumors. Option C, cetuximab, is for ROS wild-type patients, not MSI-high cases. Option D, bevacizumab, does not target the key pathway in EMR tumors. Relevant guidelines: SEN and ASCO 2023 MSI-high colorectal cancer treatment. Question 25. Radiation oncology. Prostate cancer with bone metastases. 72-year-old man presents with Gleason 9 prostate cancer and multiple bone metastases. He started on androgen deprivation therapy. What additional treatment should be considered? A. Radium-223 therapy. B. Surgical castration. C. Docetaxel chemotherapy immediately. D. Radiotherapy to the prostate and bone lesions. Answer: A. Radium-223 therapy. Explanation: Radium-223 improves survival in metastatic castration-resistant prostate cancer with bone metastases. Option B, surgical castration, is equivalent to medical AP. Option C, docetaxel, is used if patients have visceral disease or high-volume metastasis. Option D, radiotherapy, may be used for palliation but is not a systemic treatment. Relevant guidelines: ESMO 2023, Advanced Prostate Cancer Treatment. Question 26. Gastroesophageal cancer. HER-positive metastatic disease. 64-year-old man presents with unresectable HER-positive metastatic gastroesophageal junction adenocarcinoma. He has no significant comorbidities and is fit for systemic therapy. Which of the following is the most appropriate first-line treatment? A. Trastuzumab, pembrolizumab, and fluoropyrimidine platinum chemotherapy. B. Trastuzumab monotherapy. C. Cetuximab and chemotherapy. D. Radiation therapy alone. Answer: A. Trastuzumab, pembrolizumab, and fluoropyrimidine platinum chemotherapy. Explanation: HER-positive gastroesophageal cancer is best treated with trastuzumab plus chemotherapy. PS1 suggests pembrolizumab can be added per Keynote 811 trial. Option B, trastuzumab monotherapy, is inadequate without chemotherapy. Option C, cetuximab, is ineffective for gastroesophageal cancer. Option D, radiation alone, is not curative for metastatic disease. Relevant guidelines: SEN and ESMO 2023. Treatment of HER-positive gastric cancer. Question 27. Glioblastoma. Role of temozolomide and MDMT status. 55-year-old woman undergoes surgical resection of newly diagnosed glioblastoma (GBM). Her tumor MDMT promoter methylation. What is the best adjuvant treatment? A. Radiotherapy plus temozolomide followed by temozolomide maintenance. B. Bevacizumab monotherapy. C. Radiotherapy alone. D. Surgical resection without adjuvant therapy. Answer: A. Radiotherapy plus temozolomide followed by temozolomide maintenance. Explanation: MDMT promoter methylation predicts better response to temozolomide. Option B, bevacizumab, is used for recurrence, not upfront. Option C, radiotherapy alone, is inferior to the STUP protocol. Option D, surgery alone, results in poor survival. Relevant guidelines: STUP protocol, standard of care in glioblastoma. Question 28. Lymphoma. Hodgkin's disease in elderly patients. 72-year-old man is diagnosed with Tidman-2 Hodgkin lymphoma. He has hypertension and mild renal impairment. Given his age and comorbidities, he is considered unfit for BCOP or full-dose AVT. Which treatment regimen is most appropriate? A. Brentuximab vedotin plus AVT, doxorubicin, vinblastine, dacarbazine. B. AVT, doxorubicin, bleomycin, vinblastine, dacarbazine at full dose. C. Radiotherapy alone. D. Observation without treatment. Answer: A. Brentuximab vedotin plus AVT. Explanation: Brentuximab plus AVT is preferred in older, frail patients due to lower toxicity. Option B, AVT full dose, is poorly tolerated in elderly patients. Option C, radiotherapy alone, is inadequate for systemic lymphoma. Option D, observation, is inappropriate for Hodgkin lymphoma. Relevant guidelines: Echelon 1 trial, Brentuximab and Hodgkin lymphoma. Question 29. Ovarian cancer. Role of PARP inhibitors in BRCA mutations. 51-year-old woman undergoes optimal cytoreductive surgery for stidoma A-grade serous ovarian cancer. Genetic testing reveal ERCA mutation. She has completed 6 cycles of carboplatin and paclitaxel chemotherapy. Which maintenance therapy should be considered? A. Olaparib. B. Bevacizumab. C. Tamoxifen. D. No further treatment. Answer A. Olaparib. Explanation: PARP inhibitors olaparib significantly improve progression-free survival in BRCA-mutated ovarian cancer. Option B. Bevacizumab is used in HRD-positive non-ERCA patients. Option C. Tamoxifen is not standard in ovarian cancer. Option D. No further treatment leads to early relapse. Relevant guidelines. Solo on trial. Olaparib BRCA-mutated ovarian cancer. Question 30. Supportive care. Febrile neutropenia management. 58-year-old man undergoing chemotherapy for diffuse large B-cell lymphoma, presents with fever, 38.8 dec neutropenia, and 400 and hypotension. What is the most appropriate initial management? A. Immediate broad-spectrum Roman antibiotics, e.g. piperacillin, tazobactam, or meropenem. B. Observation for 24 hours with repeat blood tests. C. Oral antibiotics and discharge home. Rumnaids only with antibiotics reserved for worsening symptoms. Answer A. Immediate broad-spectrum Roman antibiotics. Explanation: febrile neutropenia is an oncologic emergency requiring immediate Roman antibiotics. Option B. Observation risk sepsis progression. Option C. Oral antibiotics is inappropriate for high-risk patients. Option D. Fluids only delays crucial antimicrobial therapy. Relevant guidelines. IDITSA and ASCO 2023. Management of febrile neutropenia.